there. My name is Dr. Kimberly Ernest. I'm a licensed psychologist, licensed professional counselor, the president of Pennsylvania Counseling Services, the founder of Live Up Counseling, and today on the How to Be Happy Hour, we're going to be talking about the therapeutic relationship.
I'm Cora Lively. I'm a licensed professional counselor.
I'm Carl Sever. I'm a licensed professional counselor, and I work over at Live Up Counseling, and also I'm a consultant at Family Based.
Hillary Young. I'm a licensed professional counselor for PA counseling at the Renaissance office.
Thank you all. So as we sort of dive into this concept of the therapeutic relationship, I think historically it's really been undervalued when it comes to a mechanism for change. And so when we talk about the data or the literature, really the leading name in this particular area is a gentleman by the name of Scott Miller out of the Chicago area. And some of you might remember Scott. Coral, I don't know if you do, but I think each of you may have been around when Scott actually came to PA counseling and did a 2-day training for us all about feedback-informed treatment. And then from out of that specific training and out of that literature at Pennsylvania Counseling Services, we developed a feedback-informed treatment tool called the iCare measure. So the iCare continues to be in the EMR today. It's pretty underutilized, I would argue, here at PCS. But it does exist where essentially the iCare has about 180 questions that it randomly draws from every time you launch it. So in the EMR, if you right-click on our client's name and you click Administer iCare Assessment, you can pick adult or juvenile, you can pick English or Spanish, and then it randomly draws 2 questions from the database. One asking about the perceptions of progress within treatment, and the second asking about the perceptions of the therapeutic rapport or the therapeutic relationship, or how connected, seen, cared for by their provider the client feels. It's designed to be administered in session with the client, like any other feedback-informed treatment measure is. Scott Miller has a great tool. It's paper and pencil. It involves the client putting like a little X to show where they fall on certain continuums. It's a lovely tool. It does involve getting out like a ruler and measuring things, which for practical applications for community mental health, we sort of went our own way here at PCS. But when it comes to the therapeutic relationship, what the data suggests is that nothing is more predictive of therapeutic outcomes than whether or not a client and provider have developed that rapport. And what the literature suggests is between 60 and 65% of therapeutic growth can be directly attributed to the therapeutic relationship. Meaning, it doesn't really matter what your theoretical orientation is, what your model or approach, whether it's telehealth versus in person, whether it's family or couples or group or individual, all those different things that we love to, sit in a dimly lit pub and argue about what is better or worse or more effective or less effective for a certain presenting problem. What the data suggests time and time and time again in huge meta-analyses conducted by people far smarter than myself is that the therapeutic relationship is the secret sauce when it comes to therapeutic change. So all of that to be said, how do we cultivate a therapeutic relationship and create an environment where our clients can feel seen and heard and evoke change? What have you all done?
I sort of think about connection, and a long time ago we decided that for a lot of our intake clients, we want to make a connection call prior to the first contact. And one of the things that I noticed in doing those was when you call clients, they're surprised a lot of times that you made that connection and you talked about, hey, there's construction, you got to watch, maybe leave a little early, and gee, what's bothering you, what's going on, maybe you can give me a little preview. And a lot of times people just react because they're surprised. And I think the point of entrance into therapy is when people are the most vulnerable anyway. And when you call them and you talk to them, and you make that initial connection, it really helps, I think, get things started,
Carl, I love it. I feel like so often when I'm talking to early career clinicians and they're saying, well, my no-shows, my intake no-shows are up. My first question is always, well, are you doing connection calls?
Right.
And they say, well, they get the reminder text or they get the reminder email. And like, that's not the function of a connection call, right?
Right.
Like you said, it's designed to sort of set the tone to therapy. It's designed to show that you're thinking about them even before you're getting started. I also think it does a lot to ameliorate their anxiety about you. Like it takes a lot of courage. I'm sure it's anxiety evoking
Right.
to get started. And so to have that, like it almost rips the Band-Aid off just a little bit. As somebody who doesn't always love to meet new people right away, like that's
Yeah.
anxiety provoking. So the meeting is at least done, and now I can get into the other pieces.
I think that even goes beyond new clients, but I'll tell my clients, and I'm sure I would have therapists who may argue against this and how much they chase their clients or not, but I'll tell them, like, if you no-show me, like, I'm going to call you and you're going
Sure.
to hear from me. I want you in that seat. Like, I want to be with you. I want to work with you. And I even get mad if they'll, like, call the front desk and reschedule but not tell me. I'm like, no, talk to me. Like, I'm a person. I want to show them that I care. You're not just someone on my schedule, but I want to, like, know what happened that you couldn't come. And, I think that impacts clients.
I think I stress about before we started rolling, I was talking about how a client who is high-ish risk has no-showed me twice no-showed me and then no-showed the reschedule. And that it takes up more space cognitively than other regular occurrences do. Like, is this client okay? Are they safe? Are we navigating a new season of treatment where they're going to need additional supports or extra layers of care given some of the other aspects of this client? And so I agree. And I am also, if you are 5 minutes late to my session, and I see all my clients via telehealth. So if you're 5 minutes late, at that 5-minute mark, I give you a call and I'm say, hey, link's in your inbox. Do you need me to resend it? Jump on now. We can do a shorter session, but I want to have that check-in. I want to have that touch point. I want to make sure you're okay.
I think another important aspect is just being your authentic self. Because I think when you kind of put on this mask or like it's almost robotic, and working in homes for the last 5 years with families, they can spot that out. I mean, they can even sense when you're not having a good day. So I think just being your genuine self. We're all different. We don't have to fit a sort of schema as a therapist.
Even using some psychoeducation about like whatever schema, like that you said that they might be bringing in, because I have clients who will like dump and then they're like, so what do I do? And it's like, hold on, like, let's talk about what we're doing. Let's talk about what therapy is. Let's talk about, and I guess this is different for everybody too, therapist-wise, but like I don't see myself maybe the expert on the process, but not on like, here's the magic wand, what to do. This is going to be more like, we're going to get to know each other. There's a process behind all this. And I get that some clients just don't know that. And that's not, I don't think, talked about in our world in general. It is more like, go get answers. And so helping them see that's not what this might look like.
I think there can also be cultural pieces there as well. Like I found certain clients, depending upon their background and their social location, may have a greater expectation in terms of like the expert mentality. I also think because I have that like PhD after it's like I'm Dr. Ernest in some circles. I think that also contributes to that expectation or belief that you're going to come in and I'm going to tell you what to do and give you my recommendations and you're going to go do them and get better. And I think anybody who's done this work for more than a minute, we know that there's no one size fits all approach to recovery. Like things like exercise, nutrition, drinking water, and sleep. Like those 4 things, if you do those things, it'll probably improve your mental health. And there's a lot of barriers to those 4 things that many of our clients, there's a lot more to it than just simply, well, have you tried going for a walk? And like going for a walk is great. And like behavioral activation is an intervention I'll use, but it's not going to work for a client that might have medical complexity or has zero desire to go for a walk and therefore will not be going for a walk. I can make that recommendation until I turn purple. It's not going to help this client.
One of the things I think I have a tendency to make things complicated when I really don't need to. The old keep it simple thing. And I think one of the therapists a long time ago, I think she worked in teletherapy. She said to me, everything changed. She had a resistant client, and she said to me, everything changed when the meeting became conversational. And it was really cool because she was struggling, and she reached that point where she was exasperated and she didn't know what else to do. She was sitting across from the client, and she looked at the client and said, in a genuine way, well, what do you need? What do you need from therapy? What do you really want? And then that was the point in which it became conversational. And as you mentioned, Coral, everyone dropped the pretense, the role, and you became two human beings talking to each other. And I remember, I go to support groups, and I remember talking to a woman who, she actually was given she was talking about herself. She was telling her story. And she mentioned how she went through some horrible trauma. And, she was in the military. She had trauma there, trauma when she came home, trauma when she was a child. You know the story. And she went through 4 or 5 therapists. She couldn't find one to connect with. And she told this woman her story, her next therapist. And the therapist listened for a period of time and then said to her, after she finished her story, she said to the client, you know what, that must have really sucked. And then the person who was, giving the speech or telling her story said, I knew then that was the woman for me because she listened, which is really what it's all about.
When it sounds like had a real human reaction
Right.
with it. And I think
Right.
that speaks to your point, Coral, the authenticity piece. And that piece that we can be authentic and have a real human reaction without being disclosing or even that's not a boundary violation. I think there are times where providers may feel drawn to diffuse their boundaries to some degree or self-disclose or maybe be less be more accommodating when perhaps holding a firmer boundary would make sense. And I think so often, sometimes it's just those little things like, wow, that really sucks. Shit. Like that sucks.
Pretty much what happened.
Yeah. And that's an authentic human interaction. It didn't involve her violating her own boundaries. It didn't involve her self-disclosing. It's like that radical, what's that?
Authenticity.
Yes, that radical authenticity where you showed up as that really sucks. And in that, I found myself wondering about, because we all work in community mental health. Now, Coral is leaving community mental health for private practice, so hopefully you notice a little bit differently there. But I know in community mental health, we see a lot of turnover within our field. Most people are not community mental health lifers like Coral and I. Unfortunately, for many people, it's for a season and then they go on to a different type of role. But I feel like in community mental health is where we have the highest acuity populations that have a tendency to be involved in services for the longest periods of time, with providers that have a tendency to have the shortest lengths of stay within those given places. And even before we started recording, I talked about how I just took a new client who I'm his 6th therapist. And one of the things he said early on was like, so, I guess you'll just have to let me know when I need a 7th because you're on your way out. It's like, haha, joke's on you. I'm going nowhere.
Stuck.
I am here. I will die in this chair. But that's not the case for many community mental health providers. And so I also find myself wondering how the client's experience in relationships beginning and ending may at times get in the way of our own joining process. I don't know. What are y'all's thoughts in that space?
thinking about like the corrective experience idea of the relationship, and like that's my jam. Like I think that's everything in therapy. And so what you're talking about is like, okay, then let's, where we can and where it's appropriate, bring that into the room. Like, I'm a real person, this happened, or I noticed I said this and you had a little face or something came up. Let's talk about it. What did it remind you of? What's coming off of me that's reminding you of people in your life? And I think if you don't bring that into the room, it does, like, it feels more clinical of like, oh, you have depression, like you said earlier, go try these things. And it's like, but we're two real people and there's things happening and we should talk about those things too. And I found that helpful.
How do you get the courage to bring that up with your client, right? Because like if I'm sitting here and I say something like, I think dogs are better than cats. Maybe you're a cat person and you're like, no, Kim, fuck you forever now, right? Like that's where your head goes. And I notice because your body shifts. There are times where I don't know that I want to walk towards that. And I've watched enough therapy tape where it's plain as day that something happened. And I talked to the provider and I'm like, hey, what happened there? They're like, listen, I don't know, but they scared me. So I didn't say anything. Like, how do you walk towards it? How do you notice it? And then how do you address it?
I think some of it is knowing where you're at in the relationship with them. Like, is this an appropriate time? Can I do this? Have we known each other long enough? And then I think it goes back to being genuine. Like, there's times I will prep it with like, all right, I'm a little nervous to say this, but I'm going to lean in. We know each other. And like, sort of showing I'm human and I'm not saying it in this dry way of like, I noticed this, but like they're seeing some of me be like a little vulnerable too. And I think that helps. I think, I forget the, who said this, but like that vulnerability begets vulnerability. Like that will be noticed.
I think it's a really good question, what scares us in therapy, as clinicians. And I think if you could imagine walking arm in arm, I'm the therapist, you're the client, and we're walking down a path or, we're taking a nice little stroll. And as the client, you'll show me your issues and we'll stop and we'll look at this issue. We'll go over here and look at that issue. And I'm fine. I'm okay to look at these issues. And all of a sudden, the client will take me to a part of the therapeutic trail where there's an issue that scares the living shit out of me because I never worked on my own personal physical or sexual abuse or being a child of an alcoholic, whatever it is. And I stop short and the client feels it and the client wants to be protective of me maybe and says, we'll talk about something else, or the client just ghosts me. And I think the reason I'm bringing it up is off of your question, Kim, I think we have to, or at least explore our own pathology so that when we're interacting with clients, Coral mentioned before our discussion about countertransference and the importance of dealing with that, because we're either going to underreact, overreact, or just zone out completely and not hear what the client's presenting.
I definitely like to set the stage at intake. I mean, so I've done therapy for the last 5 years, so 2020 Coral probably wouldn't have, but I feel comfortable enough in my own profession that I set the stage. I let them know, like, there's going to be times I'm not somebody that likes to force, but I am going to challenge. You have boundaries. I have boundaries. I'm going to ask for permission to say things. If it's not something that you're comfortable with, just tell me to stop. Like, we don't have to set an agenda and like get to that finish line. So I think that's also a good way to have that therapeutic relationship with them. Just letting them know there's going to be days I might piss you off, but that doesn't mean I don't ever want to work with you again, or, let's talk through it.
I think you bring up a good point that our clients are going to have reactions to us and we're not always going to know it. I think you mentioned, like, I'm reminding them of someone in their life. I'm also a person that says stupid stuff sometimes, probably more than the average. I'd probably say more stupid stuff than the average person. If I were, I don't know, to look at myself or be insightful there.
No, I might be a close
Are we now going to compete? Carl, is this a competition of who says stupider things? But I do think that though some of my best therapy sessions happened in the wake of a therapeutic rupture. Like some of my best, most meaningful therapeutic sessions have been the ones where the client never tells you, right? You get a call from the front desk. So-and-so wants to be transferred off your caseload. And then you're like, we're doing this today. And sometimes right? Like sometimes you can sense it. You get that gut in the session that something's shifted, or they start showing you with their attendance, or they start showing you, maybe they're not showing you, but they're showing up like 20 minutes late. So you can still like kind of have a session, but not really get into it, right? There's all these different ways that we have therapy interfering behaviors, which can emerge. And then you get that call from the front desk that says, Johnny doesn't want to see you anymore. Johnny met Hillary in the waiting room, and Johnny would like to go see Hillary now. What are you going to do? And so obviously like having to make that call and reach out and say, hey, I just heard from my office staff that you're seeking a transfer. I was wondering if you'd be willing to schedule an appointment and come in and talk about that transfer. And if at the end of that session you still feel you want to transfer, I will be happy to transfer you that way. And ultimately, if they say like, no, I won't talk to you and I still want to transfer, I will still accommodate. Unless they're a client, like every once in a while you have that client that gets a lot of transfers and they seem to only ask for those transfers when the therapist starts to get close to anything of substance. But by and large, I will always, if you say I'm not a fit for you, I will trust your assessment and I will transfer you. And for the most part, I don't even take it personally anymore because I do so deeply believe in fit. And I think I think I'm a good enough therapist, but I'm not the right therapist for everyone, and that's okay.
Yeah.
How have y'all sort of begun that conversation with clients? Because it's a difficult, I'm pretty direct, sort of right, wrong, or indifferent. I just sort of lead with, hey, I hear you want to transfer. Let's talk it through. And I've had some greats. I can remember one client in particular that I don't read previous notes for transfer clients until after I see you the first time. So that's been my own. I don't like to enter into the therapeutic relationship with a bias based on what the previous therapist thought about you. And I think at times, therapists are humans. And so even in their own notes or the way things are written, I also think the really important things, hearing it in your words is far more important than just knowing the data about your story. And so I can remember a client many, many years ago now, but she requested a transfer because I had my very first session with her and I asked her to tell me her story, tell me about her relationship with her parents, tell me about the important relationships in her life now. And as it turns out, her father had been murdered when she was younger. A huge trauma point for her, obviously, something that she was really working through. And I had gone back and read that in her chart afterwards, and she had already disclosed that to me in the session. But as time went on, she said, I just thought you didn't care about me enough to read my chart. I thought that you were lazy and that's why you didn't read my chart, or that you're too busy to care and that's why you didn't read my chart. And I said, oh no, I've since gone back and I've read, your notes for the last year-ish. This was one of those folks that had been in treatment for a long time. So I didn't read everything, but I'd read the last year or so of notes. And I said, but I like to know you on a you level. And when she told her story, when she told me about the death of her father, she told it like you would describe a grocery order, right? Like, oh, you get some milk and then some bread, like no affect, very divorced from the emotion that you would expect to be tied to that story. But where she did display emotion is that after her father had been shot, there was a stranger that didn't know him, that was in one of the houses that heard it and came out and sat with him while he was dying and held his hand and like stroked his head and sang to him while they waited for the ambulance to arrive. And that's where all of her affect was. Her affect was surrounding that helper. And so that's where our therapeutic work was. And I'm happy to say that after this rupture, we worked together for like 2.5 years. We worked together till I left the practice. But had I just gone off the notes and just gone with what was written on paper, I think I would have missed a part of that story that was so meaningful to her. And the fact that I didn't read it almost was the reason why we never met again. And so it's that balance of like, well, this is how I do things, but maybe the way I do things didn't land with this client well, and sort of having those conversations after the fact. But I can be honest, based on where I was at that season of my career, when that client asked for a transfer, I was like, yeah, let's transfer. They don't like me, then I don't like them, and I don't want to do this work, right? That's like early 20s Kim that didn't maybe have the same level of confidence as I have today. And I took it more personally, but I don't know. How do we have those conversations from that place where we're not personalizing it?
I'm thinking we have to normalize the discussion right away. A lot of times, like you're saying, Kim, when we first get into therapy, or we even later, we never really bring it up. And I think right in the beginning of treatment, laying it out and saying, look, if I ever do anything that is offensive or in any way, even culturally, is offensive to you, please feel free to talk to me, to teach me, to interact with me, because I think setting those kind of expectations in the beginning is real good. And then it's how we present too. Like, we got to normalize it and make it an everyday thing. And I think that helps, because then the ruptures that occur can, I have permission to tell Kim that I'm annoyed about this, and it's not going to terminate our relationship. Sometimes I think clients have the idea that, if they say something, they'll terminate. And what's the stat? I think it's 50 or 60% of clients, the way they exit treatment is by ghosting us. Yeah. And that goes across different, like community mental health and also, commercial insurance folks. So that's one thing. And I think the other thing is, if we don't tell them that, it's almost like we trick them into leaving, because like we don't lay the expectations out and we don't discuss those right at intake, and then they go, well, I didn't know I was not supposed to, like break appointments, or I didn't know. So I think being really clear with expectations is important.
It's always sad when a client ends that way, because there's so few opportunities in life to end well.
Right.
So few, right? Like, most of the time, we don't know when our endings are. We don't know when our goodbyes are. And this is one of the, like, to have a true therapeutic termination
Right.
is one of the few times in our life where nothing has to be left unsaid, where you can end and end well and end meaningfully. I think that's why I personally harbor a lot of resentments towards therapists who refuse their clients that opportunity. You'll never have me more pissed off than when I get a resignation effective immediately with someone who's refusing to terminate with their clients. For me, it is an ethical, it is an ethical problem, and there is no reason why you cannot talk. I understand that people have their own mental health pieces and their own stories. I also know that saying goodbye and ending with clients could exacerbate that. And I see it as our obligation as a provider and as like a steward of trauma to end well and support our clients in having that positive ending at the end of therapy. That doesn't mean you have to be with them forever. Like, you can leave, but leave right and leave well and end with your client and offer them the termination, even if they ghost you.
And going off of what you said, because there is there is a powerful phrase that you mentioned, I want this to end well, right?
Yes.
And so, we talked about radical authenticity earlier. And so looking at a client in the eyes, right in the beginning of treatment, and saying, I want this to end well, and here's what we have to do to make this end well, using those exact terms, and teaching the client this is what we need, and telling the client, look, if this is even if you're leaving prematurely, or if it's an unsuccessful, sometimes in community mental health, we have to put those terms on it. When we explain that to them, even if it's going to be an early discharge, talk to me. Let's make it end well, because we're having a relationship, right? So I love that phrase, and I love that phrase to be spoken to the client because it's instructive, and I think it's also respectful, you know.
I think so often our clients struggle with endings. I think also we struggle with endings. And when you put those two things together, our humanness can make it messy. My hope is also that when we end well, I would say probably the thing that makes me the most angry at a provider is a resignation effective immediately that belies appropriate termination. I would say second place in the things that piss Kim off that therapists do would be those who continue to have a relationship with their clients post discharge. Because that again belies one, it's unethical.
Do you mean external to?
External to the
Okay.
therapeutic
Yeah,
context.
in other words, it's not a transfer to a new agency, it's actual
No, we're
private
Facebook friends
relationship.
now. Yeah. Or
Okay.
we text each other, or I call you just to check in. And I've been in this field a long time. I've seen all of those things and more. Providers have gotten some strongly worded voicemails and letters from me saying, please stop contacting our clients over the years, time and time again. Because again, the ending of therapy to me is sacred. It is sacred. You can suck your whole therapeutic, but if you can end well, you've given your client a gift. You've given your client the gift of an ending that is probably different than any other ending they've ever had. And then if you screw it up by becoming their Facebook friend or following them on TikTok or Snapchat or whatever the kids are doing these days, you're belying the effectiveness of that moment.
And then one last point about that in terms of ending, from my perspective, and we seem to forget this a lot. The end doesn't have to be the end. And we say to the client, to the person, here's what, if you ever want to come back, you know where I am. And here's some of the signs and symptoms or things that, what do you think would cause you to come back in and give me a call? And I think outlining, we're very good at, I think, outlining the exit strategy, but also, how do we get back in? And letting the client know that, and it doesn't have to be never, ever again, here's what needs to happen to call me.
Yeah. Inoculating them to the fact that symptoms may show
They
back
come
up again.
Yeah.
Different seasons of life, different phases are going to call up different things, and yeah, to reinitiate. So we've talked a fair bit about the beginning, right? Like the connection call, how do we get started, showing up authentically, preparing them to what that relationship is. We've talked a bit about the ending, how to end well, how to try to guard against ghosts. I mean, truthfully, so many of my therapeutic relationships in recent years have ended in clients sort of like, we know we're ending, but then they won't show for the last few sessions.
That sucks.
And I beg them and plead them. And I probably do more than I think you mentioned. I might overstep a little, but I had one client.
What did I do?
I know one client recently that I sent him the intent to discharge. And 20 minutes before I'm about to do the discharge, I sent him another email. I was like, I'm doing it right now. And if you don't get back to me, but then he did. So then I kept him open longer, but then he didn't schedule an intake. So I ended up discharging him anyway. Anyway, it didn't work in the end. But we've talked about the beginnings. We've talked about the endings. What about the space in between? What about those ruptures that happen along the way that are less in the beginning of treatment or less at the end of treatment, but just through the natural course of doing therapy once you are joined?
I think knowing signs is probably important. I think of some of my clients who have the best attendance ever, where you're oh my gosh, they missed once in 5 years, but then they miss 2 in a month or something, and then thinking okay, what's happening here? What's going on? Would something different? Do you need less? But But those are those hard conversations, like you said earlier, where it's like leaning in to, okay, now we have to talk about us, and that can be difficult for therapists, I think.
I think check-ins are very important as well. Just being in family-based, I've had a lot of instances where families are like, oh, we love Coral, but we didn't talk about this and we really wanted to. And that was kind of like in the earlier days. So I think it's good just to check in, be like, how do you feel things are going? Are these the topics you want to talk about? Is there something that, we haven't scratched the surface of that like you're ready for? Or like, how do we want to get this conversation started? I think it's good for them to see that we also want feedback, because it, like you said earlier, it is not a one size fits all. We want to ensure that you're getting the therapy and the treatment you need, because we're getting paid for it, but also we do empathize with you. Like we want to see the change happen because you came in to do this. So I definitely think doing check-ins, because we don't always have the answers.
And Cora, I mean, that your intuition aligns with the literature beautifully. Like those regular systematic check-ins, even if like it's all under the guise of like promoting different tools, like the Working Alliance Inventory, which is a great one. It's like a 30-item measure. You can find it online. You can administer it to your client and like really get some good insight and data, to a snapshot of exactly how they feel in this moment about the work that you're doing. But I think far more fruitful are those frequent, regular check-ins. Like I had one client that over the course of our time together, she would often just mishear me. Like, I don't think it was on purpose, but I think she had a lot of, we were doing some pretty intensive trauma work. I think she was often dysregulated when we were in session. And then I think also some of her trauma pieces had really heavily colored the lens through which she interprets information. And so frequently what I would discover is like she was seeing me, and then she was in couples therapy. And so she would like leave my session and the next week tell her couples therapist something that I definitely didn't say, but like in her head, that's sort of how she interpreted it and heard it. And sometimes it was she felt like I was being judgmental when I truly wasn't. Or one time she felt like I was advising her to go for a hike alone in the woods. This woman was in her 70s. She ambulated it with a wheelchair or with a walker. I did not make that recommendation. I don't think that is safe to go walking alone in the woods when you ambulate with a walker. So like there were times where it was, she was not picking up what I was putting down. And so I started systematically each week to start session. I would say, so let's do a recap. What did we talk about last week? What were your action steps? What were my action steps? All right, let's get to it. And it served as a really nice bridge for therapy. Because also my ADHD squirrel mind, like, you could come up with a crisis of the week every week for about a month before I realized you've taken me down a rabbit trail every single session, and we've done nothing meaningful in our time together. So when you have that bridge or that check-in to start therapy, one, you're way less likely to have premature attrition, because just the sheer fact that you're asking reduces the probability of your clients dropping out. But two, it also allowed for a lot of clarity along the way. And she's like, well, I felt like you were really judging me for not wanting to go to my grandson's basketball game. I was like, no, not at all. I was empathizing with you that your mobility concerns and your driving impedes your ability to get this. So like I hadn't intended an empathetic response. She felt it as a judgmental response. That's a really important point to clarify. And I don't think you necessarily discover them without those more frequent and intentional check-ins.
It reminds me of Irvin Yalom, who I love. And I can't think of the what is that? Like Letters to New Therapists. I can't remember what that's called. Yes. Oh my God, that's such a good book. But he has like him and a client after sessions for so long wrote, like journaled separately what their favorite part of the session was or what stuck out to them, and then compared it. And it was like never the same. Like it would be like, I think it was probably that insightful thing I said. And then she would say like, no, it's you remembered like my favorite color, or, something unrelated. But it showed like the power of not so much what we use or just who we are and the fact that we're humans and people. But I think it also speaks to your point of then let's talk about what stuck out, because what I remember may not be how you saw it or what you felt in the session too.
I think he talked about, and I've heard a lot of people talk about normalizing ruptures as part of the therapeutic process. So it's something we can just do. And I think he said that in that book, Hillary. A good session is you laugh with the client at one point and you also disagree with the client. And you normalize the process of that because that's part of the way people heal. They recognize that the relationship is robust. You can have a relationship with someone, the therapist, or someone else, and disagree with them, and it can the relationship can continue.
And I think is often stronger
Right.
as a result, having that disagreement.
Right.
I think there's also a time to hold your disagreement at times. I've worked with clients over the years that maybe you're not mandated, but are engaging in more problematic drinking
Right.
or spending or scrolling or values incongruent sexual behaviors or kind of whatever it is. And I think there are times where challenging and confronting them on those things is really what is called for in that moment. And then I think sometimes falling back and empathizing with them in the suffering and the pain and the discomfort of that having so much power in their life is where it is. And it's almost that like it's a dance where accountability and like, hey, I'm noticing you're struggling with depression and using medical marijuana every day, which happens to be a depressant. And I'm wondering if these two things may be related. No, not at all. Okay. Okay. Let's talk about something else then for a minute and we'll come back. But I think also what I've noticed with some of our providers and something that I'm really interested in this year is that if our clients don't take our advice or take our recommendations or see things the way we do, sometimes there's a therapeutic rupture on the part of the provider. And so I've recently worked with some providers who are saying like, well, they're not following my recommendations, so I'm going to discharge them unsuccessfully. And there's moments where I'm like, whoa, 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 no, 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 no. That's just a symptom of their disease. Let's not discharge them for being symptomatic. It's not that we don't have boundaries, but there are times where we address things therapeutically and symptomatically versus addressing things administratively and like, I'm going to withhold my care from you. And I think sometimes that has to do with our own rupture. I don't think we do that to the clients we like if I were to, just be throwing out a hypothesis. I think the clients that we really like and we feel connected with, we maybe give more chances to. And the clients that brush up against us in a way that doesn't feel as comfortable, we tend to give less chances to. Is my working hypothesis, but perhaps
I
not.
think you're right, and I think it's much easier to be dictatorial with clients who we don't like. And I also think that there's a tendency, and I don't think it is as evident now as it was 20 years ago in the field, especially with people with repetitive behavior like addiction. I remember working I came to this drug rehab program for adolescents. They asked me to, direct a program, and one of the rules, the cardinal rules of the program, and it was an adolescent dual diagnosed program, was if you get caught smoking once, you get discharged from treatment from this inpatient program. And, it was a what the fuck moment when I said, wait, guys, we're discharging people for their symptoms that we're supposed to treat. And, my head, I had to hold it and put like a cap on to keep it from exploding. And it took a while, but it's that attitude you're talking about, Kim. We feel sometimes a clinician feels secure by being dictatorial and being controlling, and that's part of us feeling secure as clinicians, but it usually comes back to bite us,
I think a privilege that PA counseling and Live Up has that, in my opinion, should be used probably more than it is collaborative documentation. I also think that is a really good way of establishing a therapeutic alliance because there's a lot of people with anxiety that like, oh, they're probably writing the shittiest things about me. And so you turn your computer and you're like, hey.
I'm writing the least amount about you as I possibly legally can. Let's be clear.
This is what I'm writing.
Yep.
I would like your input. What did you get out of today? What do we want to do moving forward? I think that's wonderful. I used it a lot in family base. I think that's just a great way for any area you're in therapy to do, if you have the opportunity to do so.
Collaborative documentation was a game changer with one of my clients. And it was a client that I had seen for about 2 years prior to starting collaborative documentation. And I actually started doing collaborative documentation with him before PCS started doing collaborative documentation, because my gut was the fear that this person had was what I was writing after the fact. And I knew that this client had been gang involved 30 years before I ever met them. And I knew this client had some behaviors that occurred during that season of their life that had no statute of limitation. So from that, you can make whatever assumptions you'd like. And this client had significant trauma and moral injury surrounding that season of their life. And so we needed to go there, and the client would not go there. We were doing EMDR. I was taking them to EMDR consultation, and you just watched like the session just like putter out every single time we started to get to where we needed to be. And so on a whim, and I saw this client via telehealth, I started sharing my screen and writing my notes at the end every single set. I wasn't being compliant with the collaborative documentation policy because I didn't know what we need to do at the time. So like, please don't audit me. Chart's closed, so you can't audit it. But I started sharing my screen, and at the end of every single session, showing this client exactly how I documented our session. And it changed everything. It changed everything. It allowed us to talk about the things we had to talk about. And that client's since been successfully discharged. To my knowledge, is doing quite well. But it was like this thing in their early life that had had so much power for so long, and the belief was I have to carry this alone forever. And collaborative documentation completely changed our therapeutic relationship.
Yep.
I also find myself thinking, Carl, as you were talking about being dictatorial and how we as providers, sometimes our own feelings impede our ability to be effective. And I think discharging a client because they use a substance is like a really nice example of ways in which we err. We see it often in our forensic work as well, where we discharge a PSB client for engaging in PSB-based behavior, like, I don't know, looking at porn or things that they shouldn't be doing. I also think there are times where our clients that have patterns of engagement that are less severe, if you will still engage in therapy interfering behaviors. Like our clients that grew up feeling less than or unimportant or rejected may test us by creating circumstances in which we may wish to reject them or just, and it's still a symptom of their mental health. But I think so often we take it more personally than is helpful, or we give it more power than is useful versus kind of zooming out. And what I've always done in those instances is kind of zoom out and made more process oriented discussions. Like, feels like you're trying to pick a fight with me and I'm not really sure why. Can you help me understand? Or, kind of whatever that is. And that's always been my style. Like I name it and take the covert and kind of put some light on it and see if we can't work it through. But what are some other patterns in the absence of being dictatorial and saying, like, I'm going to put you on a commitment to treatment contract, and if you miss 2 more sessions, I mean, what are some, which is great, and I think we have to do that at times, right, to protect our own liability and to hold a client accountable. But what are some other ways that y'all have kind of leaned into those conversations and made it more therapeutic versus compliance driven, I guess, for lack of a better way to say it?
I think, to be conversational and not legislative, and recognize that when we're in that space where somebody's testing us with behaviors, we keep it conversational and talk about the behaviors and talk about how we might feel about the behavior and or comments that are being made. I think that's a big deal because it shows the client that we're not afraid. And we're going to sit here for that, and we're going to stay in the space, and then we're going to get to talk about. And I love a lot of acceptance and commitment therapy because we start talking about what's the function. And when you can converse about the behavior in the real time of the session and talk about, okay, you just call me a dumb shit. And I don't like when you call me a dumb shit, but it sort of makes me smile. Let's talk about where that comes from and having that discussion. I think, we've arrived with the client. So that's sort of the way I handle that kind of stuff. And I also use humor a lot, especially if you have to be careful because it could escalate it. But if you know
Sure
the client
can.
well enough, you can have a little bit of fun with those behaviors too.
I had a client years ago who she would yell at me probably about every 6 months, get real mad at me. And then she'd come in the next session. She's like, I'm sorry, my borderline was acting up last, like her sciatica. My borderline was acting up. I'm so sorry, Kim. I'm not mad at you. Just my borderline was out of control. And but then that was our language that we used. Like we started talking about. So when your borderline starts acting up, not just with me, because I don't like it when you do it with me, but I'm a professional. I can handle it. But when you do it with your sister or your daughter or your partner, or like that's where this generalizes, right? That's why this matters, is because those relationships matter. And so if you can develop the skill within the microcosm of therapy, hopefully then you can go out and have those conversations with your natural supports.
And I think when the relationship develops, like if you set the stage right in the beginning and you're doing what you need to do to develop the relationship can handle those kind of events really well. And your relationship with her when she comes in and goes, that's my borderline acting up, then that leads to, I'm sure, to a discussion of, yeah, that can be hurtful. How does your borderline act up with other people outside of this relationship? And let's talk about that. And do you want to change that? Because that borderline acting up behavior might be essential to her survival based on her trauma and the events that occurred in her life. It might be the way she keeps people off of her. So I love that example. In fact, I might, whenever I act funky, I might say my borderline's.
I think to do that successfully as a therapist is to practice what we preach and like work on our own anxiety. And I can think of some clients, especially telehealth has opened up. They now have my email. So we've had to set boundaries on like, if you're emailing me, I probably won't respond, until next session. But sometimes that's used to tell me how like something I said in 1 second of our 45-minute session, like upset them. And, how do I in that moment, knowing that it's symptomatic of them, take a deep breath, put it kind of in a different area of my email so I don't have to look at it and know, we'll talk about that next week. But I think for newer clinicians who that, and myself included, like years ago, where it would be like, okay, like they don't like me, something's going on, do I have to discharge, are they, and it's like learning to calm down, like work with our own anxiety of like, we'll handle that, we'll talk about it. And I think that's a big dealing with uncertainty. You don't have to know exactly how next session's going to go or what you're going to say. You have time and just kind of settle yourself in.
Yeah.
You mentioned earlier about Scott Miller and common factors of I think 11 common factors of psychotherapy that really enhances the relationship, and they did all the research. And one of the things that he talked about in the article I read was the ability to tolerate extremes of emotion was one of those common factors that, kept clients coming back. And so if our ability to tolerate that extreme emotion sometimes makes a client feel safe. And, you can express that to me and I'm not going to wilt or fall apart in the session. And that is a show not only of respect, but for love. Now, I'm not advocating that we should be abused, but, I think that is a critical piece. And that example was so cool because she felt comfortable enough to do that to you and then come back and apologize for it. And that's because, in that case, you could tolerate the extreme behaviors that sometimes our clients show us.
Well, and I think in that instance, I was able to tolerate it, but I did not accept it. Did not like. I also said, "Hey, you've now yelled at me for like 11 minutes, and I've sat here in silence while you've done it. But I've hit my limit for what I'm kind of willing to tolerate in this moment.
Right.
So now, how do we switch gears?" And I think in that moment, a really artistic, creative client. So she had actually developed. There's a book called "Taming Cartoon Elephants." And it's all about like emotions and cognition. It's a comic book, but it's all about emotions and cognitions. I've used it therapeutically for years. I just love this book. But she made her own version of it, of her cartoon elephant. And she also struggled with addiction. So she had multiple elephants and they all worked together to like do different coping. So she had made her own like manual on like, how do I tame my elephants? And so I think after about 11 minutes, 12 minutes of being screamed at about things that were not within my control by any stretch. It was an inpatient facility and she had lost some privileges because while off the unit, she had done some things she wasn't allowed to do. Like it had nothing to do with our therapy, but she was not happy with me in the moment. And then I said, well, what can we do now? And she pulled out her workbook and she's like, well, I guess I could work on my workbook. And so like we got that. So it was a balance though. Like I'm not going to lock horns with you and scream back at you in this moment. I'm going to tolerate your symptoms. And then at a certain point, I'm going to say, okay, that's enough now. Like you've gone from self-expression to you're dipping a toe into the abusive side of the line. And I'm not going to do that with you. If you'd like, if you cannot tone it back a bit, we can end the session now and reschedule for later. And she didn't take me up on that in the moment, but I think that's also a good balance. Like we tolerate your symptoms. I will not tolerate your abuse. And there have been numerous times where, especially when I was more in the role of a gatekeeper in an inpatient facility where, we were therapists, but we also played a role in what privileges people had and things like that. I would often get yelled at times. And where I really had to go with it is that like, hey, you can no longer yell at me. I'm here to listen, but
Right.
you can't yell. I'm here to listen, but you cannot posture over me. Like you can't stand up and stand over me and yell. You've got to sit back down again. And I will say very calmly, but very plainly, like, hey, I want to hear you, but you have to sit down. I can't hear you when you're posturing over me. Please sit down. If you don't sit down, I'm going to end this session. I
Right.
need you to sit. So I think there is that balance. And I think the only way we really learn it is by going through it as providers.
There was only one situation that I could recall here at PCS where a client touched a therapist aggressively. She grabbed the therapist by her shoulders and squeezed. And when we looked at that event, and the reason I brought it up, Kim, is because it speaks to what you're talking about. Some clients, obviously, not a lot, but there's a percentage of clients that have a dark side and will groom therapists and will groom them in ways that they groomed other people in other relationships. And the therapist, when we did a really deep dive into what happened, it was a grooming process. The client would stand up and shout, yell, and then sit down. And then the next session, it was slam your hand on the table. And as the next session, it was kick a waste can. Till finally it reached that point of grabbing the client and shaking her. And I think it goes all the way back to what we were talking about in the beginning, which is dealing with ruptures like that, because those things are like ruptures in the session. And then when you don't deal with a rupture, sometimes things progress, and it might not be aggression. It might be a client leaving the session, or it might be a client distorting what you say. But the point is, I think dealing with this stuff immediately or as soon as we can, as long as it's not hurting the client.
No, I agree, Carl. I think that timing is everything. I think also our own tone. I think you'd mentioned it. Maybe you too, Coral. Like being mindful of our own experiences, using our own therapy, using our supervision, using our consultation. I've now been independently licensed for, I think, going on 12 years, 14 years, something like that. On a regular basis, I will call people, trusted colleagues, other professionals, former supervisors. I still have friends from my grad school programs that I'll call and say, hey, I need like just a completely different perspective right now. And I need someone who I know and trust. Because also at PCS, I'm in a unique position in that like I have a lot of power in every room I walk into. And sometimes it's difficult for people to speak truth to power, right? So I could call Hillary, and I think I think Hillary's a fantastic clinician, and I trust Hillary's clinical acumen. But I also worry about putting people in a position where they have to say something to me that I might not want to hear in that moment, and creating these. So I call former colleagues, supervisors, places where those power differentials are maybe a little bit more even, or at least the perception to me is even. And I say, like, either I'm having a really strong reaction to this client because I don't like them, and that's not normal for me. I always really like my clients. There's just something about the therapeutic relationship and getting to know them. And when people show up authentically and tell you their story, like I always develop just this sense of like, I care for you and I'm rooting for you forever. Like I will never stop. So when I notice early on that I'm really struggling with that, to me, I need to tell on myself. I need to go to somebody who I know is comfortable calling me on my shit or mentioning something that I might not want to hear, or maybe just reflecting and being present with me, to allow me to see what I might be missing in that space. And I think so often, though, maybe others are reluctant to do that. Maybe because of different, like we really want to impress our supervisors, or we don't want to appear vulnerable with our colleagues. Or I know in grad school, at least in my grad school, there was a lot of like competition between the cohort, like who's going to be the most regulated and doing really hard therapy. You know what I mean? So it was like, it doesn't bother me. Well, I can work with murder. Well, I can work with sex abuse. You know what I mean? Like there's like almost this competition of who's going to be the most resilient therapist. But I think that impedes our own effectiveness as well. Like going to a colleague, going to a supervisor, taking it to treatment team, taking it to group supervision is one of the best ways that we can be the most effective in that space when a client gives us trouble.
It's funny, there's a old expression, the best therapists are the ones who could take their clients to, consultation or a big clinical meeting and appear incompetent and say to the whole team, I don't know what the hell I'm doing, and they become psychologically nude in front of a whole bunch of people. And that's difficult. I think family-based is really good at staffing cases and putting therapists in positions where they have to grow within the larger group. And
family-based uses tape, and
Yes.
no other treatment
Yes.
modality will use it.
do you feel strongly about
I really do, Carl. I really feel strongly about this. I wish more people would film their sessions and use them to grow. And it's my own personal bias, right? Like, that's how I grew. I grew because every time I was doing therapy for the first 5 years of my career, the tape was on, and I would have a supervisor that would pick a tape at random, pick a spot at random, and that's what we were watching. And I would just be there like, oh, please, let it not be this session. And I had one supervisor that I don't know what it was, but he just knew. Like maybe he would like move his mouse around and he'd hear my heart start to beat fast. I don't know, but he always knew. He always picked the one session that I wish he would never click on. So yes, Carl, I do feel really strongly about it. And if you're struggling with your countertransference towards a client, you should film that client and take them to your supervisor. And if I'm your supervisor and you tell me you're struggling, the first thing I'm going to say is, when can I see this client?
when can I see the tape?
When will you be bringing tape?
Yeah, I can't tell you how many times I've cried in supervision.
So many times.
It is a vulnerable time, but it's always helped me grow. I noticed for myself, like I will sit there and complain, like I just don't like this person. I don't know what it is. And like as I'm saying it, I'm reflecting like, oh, this is why. There's a specific population of people that I worked with in family base that I still struggle with. And it's kind of like personal stuff. Beautiful thing about family base is it helps you heal your own stuff.
Yeah.
But yeah, there's still definitely a struggle. And Brian, shout out to Brian, he always just was like, okay, let's figure out what part of this is like truly affecting you. And he's like, you're human. It's okay to cry. There was always tissues next to me. So, but yeah, I definitely think it's good for us as humans, like, because we are human beings. Like, I know sometimes we are seen as you're the therapist first, which means you have no heart, you have no soul. You have to stick out a session when things are going haywire. Like, I can't tell you how many times I've had families go, you can't leave. And I'm like, I've been here 2.5 hours. I settled things. You started it. I'm not going to be here forever. I know we're here for 8 months, but like, this is my boundary. And like, my challenge for you is I'm going to walk out the door because no one's hurting themselves. It's just like pettiness. Figure it out. We'll reflect later. Like, there have been those vulnerable times for me too that I've been questioned about my job. And it's like, no, this feels right for me. Like, this is my growing experience because I have a habit of people pleasing and wanting to take care of everybody. But yeah, I think definitely being vulnerable is huge with growth in this job.
Coral, I love that you just brought into the room a topic we haven't really spent much time on, which is the clients that we really, really like.
Yeah.
And the clients that we may overfunction for, and the clients that may groom us differently, right? Like you talked about the client that really grooms us to be ineffective on one side of the line and tolerate things we shouldn't. The inverse is there are also clients that'll groom us to be ineffective to the other end of the extreme, which is we overfunction, we oversupport, we infantilize, or almost treat a client as if they cannot do it in the absence of us. Well, spoiler alert, they've done it in the absence of us for how many years? We are not that important. And I think we sometimes overemphasize our own importance, much to the detriment of the client. The client doesn't need us. The client is surviving without us. We're here to support them in finding a better way to live. But never should we become so central that the client cannot function without us. If we have, we've made an egregious error along the way.
Induction's a real thing.
It's a very real thing. And I think it happens to all of us to some degree. It's about noticing it and saying like, ooh, I need to reorient. I need to kind of get back to homeostasis or whatever we're driving towards.
We used to do a training where we would identify, what our trauma was and, what our leanings were in terms of how we did therapy. And then, we would then speculate about how that would impact our trauma on the way we do psychotherapy. And it's amazing how specific people would get in that training and the insights they would have in terms of like if you were living with a father who was an abusive alcoholic or a mother who was divorced from your life, and then how that can directly impact on how you work with somebody in that area. We sometimes, especially the ones we love and identify with, like I have a client who is a parentified child like I was. We become, like you were saying, Coral, much more oriented towards that person. A lot of times we will overfunction for them and sometimes even excuse their behavior because they become our favorites. And, I always used to kid around with therapists in that training. Okay, who are your favorites and who are the ones you can't stand? And let's deal with that.
And who do they each remind you of?
Yes.
There it is.
Yes.
There it is.
The next question. Who do your favorites remind you of? Who do your least favorites remind you of? You probably have a meaningful answer for both.
Yes.
So one of the things we do here at the How to Be Happy Hour is that we accept questions from the audience for our panel. And so I have a few here today. We do have quite a few upcoming How to Be Happy Hour topics. So the entirety of season 3 is going to be focused on relationships, different types of relationships. So our first episode was looking at friendships. Obviously today we're looking at therapeutic relationships. Some of our upcoming topics are going to look at romantic relationships, the parent-child relationship when the child is an adult, which is a topic I'm really excited to get into. In the next couple of weeks, I'll be scheduling a cousins pod because I think cousins are really important relationships. I mean, who among us doesn't get up to some shenanigans with the cousins? And then additionally, we have a grandparents pod on the list. So all kinds of different types of relationships. So if you have a question for any of our panels about our upcoming pod, kim@howtobehappyhour.com is the best way to submit that. But in the interim, one of today's questions are, what do you do when you sense the therapeutic relationship just isn't jiving, when you're just not connecting with that client? Either you don't feel that rapport with the client, maybe you find the client to be unlikable, or you just feel disconnected from client, or the inverse of that is the client doesn't feel very connected to you. So what do y'all do in that context where the rapport feels less than ideal?
I think, like we said earlier, I'll try to lean into it. I'm thinking of a time that I worked with somebody who I felt like there's no way they're connected. To me, they seem uninterested. And then when we leaned in, it was like, this is so helpful. And I was like, what the heck? So like, so I think having some of those conversations, like just checking in where we're at, how we doing? And sometimes you're surprised, and I'm sure sometimes surprised the other not good way as well. But I think you don't know unless you have some of those check-in points, like we said earlier.
You know, you brought up a really good point, Hillary. I've often assumed that relationship wasn't going well, and the client goes, oh yeah, it's fine. I'm really enjoying this, and I'm really benefiting. So I think the check-in is good, and I think the other piece is, can you laugh together and can you have fun? And so I think trying to have fun with the client is not only a way to bring us closer together, but also, and it might be even telling stupid dad jokes. I mean, whatever it is that works. It's not only a way to bring us closer together, but it's diagnostic too. And so I think making that effort and being frank about it, you know, hey, maybe we got off on the wrong foot. What's going on? Let's talk about it. This is a thing we can talk about. This is what we do in therapy. And I think doing that is really, really good. And then what do you know, are you reading a book together? Like, what books do you like? What shows do you like?
Just be careful. Sometimes they'll show up with a spoiler.
Yeah, I hear you.
I've had clients ruin shows and books for me when I've used that strategy, Carl.
Or they may ask you to watch something that you really shouldn't be watching. So,
Also true.
but the point is, developing a commonality, I think, is really what's cool. Yeah.
Another question that was submitted for today that I think is an interesting one. How does the language we use when we talk about our clients in case conceptualization, in supervision, in treatment team meetings, how does the language we use when we talk about a case impact the way we feel about the case, or even impact the course of the case from y'all's perspective?
I think language, you know, is projects what our thinking is, and I've seen it where therapists might be frustrated with clients, or therapists might be, you know, sad about clients, and sometimes therapists get angry about clients, and they think about clients in a very legislative way. They think about clients and project that in their words in a way that is very factual, and we don't go to, it's knowledge versus understanding. Knowledge is great. We need it. DSM, facts, statistics. But we also need understanding. We need to know the client's story. And I think our heart gets involved when we know the client's story. Our words and our diction, our language, everything changes when we know the client's story. That's translated, I think, into the way we relate to the client. They feel it. And I think I heard some crazy stat where somebody said that a person judges another person within like a thousandth of a second when they just, boom, they look at them and make that judgment. And so it's so important when we know the story and we can project emotion and honest love and concern for a client, they pick that up. But if we're thinking legislatively, we're in trouble. That's sort of the way I look at that.
I think it was Oprah did a special a while ago about trauma, and she said when you meet someone difficult, changing the language of what's wrong with you to what happened to you. And I always try to think that sometimes with
That's
clients
a
too.
really
Yeah,
cool
I loved that.
idea.
I loved that. Because we are human, so it's easy to sit with a client and be like, God. But then if you can slow down and say, like, nobody is necessarily born this way and what happened, and it's a whole different level of empathy.
You brought up that point, which speaks to the staff meeting I was thinking about, where we had this woman who violated all the facility rules, right? She was getting ready to be discharged. Everyone was inducted into, she was the villain. She was a pain in the ass in group therapy. And what happened was someone said, "What's her story?" And when she told her story, I was bawling. I mean, when I heard this story, it was like it tore me up. And the bottom line was it changed the way we felt about that person. It wasn't, what are you doing? What happened to you? Oh, no, now we understand why you do what you do. And the whole mood of the group shifted, and it was, okay, how can we help this woman, not what should we do to this person? So that triggered a memory.
Carl, I think you bring up a good point. Just kind of like everything else in our minds, it always goes to the negative. So kind of a pattern I just kind of thought about was we always talked about the families that gave us the most trouble. It was very rare that we were like, guess what this family did? And it was wonderful. It's always right to the negative because I think inherently that's what happens. So I think too that, and like your story, you bring up a good point, and it spreads like wildfire because as professionals, you're in agreement with things like, oh, well, if they think that way, then I have to think that way.
Yeah.
But just kind of taking a step back.
And I've been in those consultations like in a family-based clinical where you have like 80 brilliant minds all watching one case, and somehow collectively none of us are strengths focused. Like collectively we all fall into like, oh, look at that addiction, and look at that therapy interfering behavior, and look at that lack of emotion regulation, and should this person even be a parent, and like blah, 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 blah. And then all you need to do, there are moments where I've been in those meetings and I've said, all right, the next person that raises their hand better have something strengths focused to say. And for the next 5 minutes, I want to be strengths focused.
Right.
We need to be strengths focused. And for good measure, let's also be trauma informed. And if we do those two things, let's bring those two things intentionally in the room, the whole room changes.
Yeah, I love to say in the middle of that, I've said this several times in a staff meeting, looks like this client needs a lawyer. I want to be the client's lawyer now.
Yes.
And then all of a sudden, shit changes. I'm the attorney. Let's go. I've heard other people do it too to fight the induction that you were talking about.
Yeah.
And I've had
The staff get inducted.
Yeah. Oh, for sure.
absolutely. And I've had folks that, I'll say, all right, let's be strength based. Like, what are they really good at? Tell me. They're really good at pissing me off. Or they're really good at missing sessions. And it's like, well, I realize we use strengths-based language there, but that's not what I was looking for. Let's try again. And so I think that, I don't know. And it really shifts your own ability to have empathy. I think that Not Oprah said it much better than I did, but when I started my career working with those who have committed sex crimes, I think that was the way in which I found empathy for that population, and a population that is sometimes hard to find empathy for, because not only do they have this part of their history, but oftentimes also interpersonally. They struggle interpersonally, and therefore those encounters tend to be more challenging. They can be more combative. Power and coercion is a part of their clinical picture, which sometimes plays out in the psychotherapy room. And I remember very early on, I had a supervisor who was just this lovely. He was crazy, I think, on a lot of different levels as well. But the first and foremost, he said, "Would you trade lives with them? Would you trade lives?" And almost entirely, the answer is no. The answer is no. I would pick my life again almost every time. And then if you wouldn't trade lives with them, why wouldn't you? And it's like, well, this and this and this, and they've got this. They were in jail for 20 years and blah, 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 blah. Like, then how can you expect them to be on the same level as you are? How can you expect them to be on the same page as you are? And then I think he looks me dead in the eye and he says, "You're the professional, act like one." So that's back when we could yell at our supervisees. We don't get to do that anymore in therapy, and probably for a good reason. But it was impactful, and it really sort of shifted that.
I think ACEs, the adverse
Yes.
childhood experiences, oh my goodness. I think if everybody utilized them, I know in family-based we do, and I did make a suggestion for clinical, if that was attached to the clinical, I'm curious if the negativity would shift for the parents, because I have fallen victim of being like, fuck that person.
Yeah.
You know, just from that short video clip. So yeah, I've been there. But
I think this leads really nicely into our very last question for today, which is, what do we do with countertransference when we know it's affecting the therapeutic relationship? And I think I've mentioned briefly, like, I tell on myself, I take it to supervision, I take it to consultation, I seek out an environment that is not an echo chamber. I think sometimes we look for, like, we'll go to a friend, like maybe in family-based, you'd go to your partner, or in outpatient, you'd go to like your office suite mate and you'd be like, "Let me tell you what this person has done to me." And that person is like a good friend, and they show up in a friendly way where they're like, "Yeah, fuck that person." You know what I mean? And like, that's not helpful when it comes to addressing countertransference. So I tell on myself to somebody who I know cares about me in a way that will hold me accountable and encourage me to look at myself. But what are some other ways that y'all navigate countertransference?
I definitely am one that needs to talk it out, because sometimes when you get that fit of like you're seeing red, for me, I'm one that if I just kind of lay it out, I take a minute and I'm like, I don't even know why I felt that way. Like there's something that sparked it, and then it goes back to there's a reason and let's work on it. So I'm definitely one to not hold it in, because if I hold it in, it's just going to be worse.
Right off of that, Coral, we had a sign in our rehab that said, "Talk it out before you act it out." And I think when we have confusing feelings as clinicians off of a session, and it could be anger, it could, whatever it is, whenever the feelings are extreme, I think that's a signal for us to talk to someone about it, someone who knows, bring it to session, bring it, supervision session, bring it to team meeting, bring it to staff meeting and talk about it. And I always used to say to the crews, if a client activates you in any way, like gets you up, whether you're angry, whether you're depressed, whatever happens in that session, something's going on internally, probably self-conscious or subconsciously if you can't identify it. And then the way it comes out is you bring it to the surface and talk about it, and then start boo-hooing, have the tissues, but that's how you protect the clients and yourself, and that's how the growth occurs,
Yeah, I've found if you don't talk about it, you sort of create your own reality of like what's happening in the room. And then when you talk to somebody who can challenge you, and I'm thinking of recently talking to someone who's a bit of a mentor to me, and when they said, "Oh, it sounds like this is happening," I was like, "Oh shit." Yeah. So I think just making sure that we're doing that. And sometimes I like to journal too, and I think sometimes after a difficult session, just getting things out myself too can be helpful, and then figuring out what to take and what's helpful from that or not.
I do a lot of journaling as well, and I think that that is sometimes helpful in helping me get my sometimes just getting my thoughts in order. I think sometimes, I don't know, I'm sure many others have some, but my thoughts will run until I slow them down with pen and paper, and then it's that I think Penny Baker's the big researcher tied to this, but how just transformative just that journaling pen to paper can be, and that's often helped. I would say one of my go-tos in the moment when I'm having a countertransference reaction is to just be curious.
Yep.
Whatever it is. Like right now, I'm about ready to like I'm seething. I know this muscle right here is tight. My jaw is tight. My thighs are clenched. I'm frustrated. Like, so what? Help me understand how you came to arrive at that specific belief, or what about your history kind of makes that feel true, or even a simple "tell me more" is sometimes a really nice segue between my mouth that can sometimes move faster than my brain can, and my own reactivity, right? Because I am a reactive human. Like I'm diagnosed with ADHD as a little girl. Like I've spent my whole life trying to have distance between the thought and the behavior. And so I know for me in therapy, when I'm activated, to just be curious and to make sure I'm not sticking to statements. I'm not like trying to dig into any brilliant therapeutic insight in that moment. Tell me more. How do you make sense of that? What's that mean to you? Where'd you discover that? When did that begin? When did it end? And just staying there is one of the ways in which I can protect myself in the moment from becoming reactive.
I think continuing to be curious about our own behavior too, like, okay, by 37 minutes and 30 seconds, I'm standing up with this client, and this other one, I'm like, crap, we're almost at the hour. So, like, what's going on? And just kind of like recognizing some of those things too.
Yeah.
An indication, and I think we always talk about transference issues with individuals, but sometimes I think we look at groups, classes of people, like classes of therapists in a staff meeting. And I've helped several people who could not talk, professionals in team meetings and larger staff groups of staff without feeling some severe anxiety. And, you know, a lot of times it came down to intentional practice in zones of discomfort. But, you know, as we were talking earlier, talking that out, and what does that represent? Well, I always was told as a child I was dumb, I couldn't amount to anything, I wouldn't. So I'm replaying this narrative. Now it's time to talk with peers and professionals. You don't know anything, shut up, don't talk. You're going to make an asshole out of yourself. And so working through that is really important, I think.
Is there anything left unsaid? I mean, obviously, we could talk about this topic for days, and I'm really looking forward to in a couple of months. We're going to come back, not necessarily this panel, but I have another group of panelists that are going to come back and talk about the therapeutic relationship from the perspective of the client. So they're mental health professionals, but have also spent some time on the other side of the couch. And so we'll spend some time unpacking that. But truly, I think the therapeutic relationship is one of the most meaningful, impactful. Obviously, I'm biased, but I think it's such a beautiful relationship that we don't always speak about enough. So is there anything left unsaid for today before we end?
I think one thing that I was thinking about, we didn't get a chance to talk about it, but maybe down the road, Kim, is healing rituals in therapy sessions. How we address clients' repetitive rituals, how we say hello, how we say goodbye, how we, you know, the feng shui of our office, how we decorate our office. And those repetitive healing rituals that we do with clients, for example, with chronically mentally ill clients, I used to do safety inventories all the time, where we would go through a list of safety issues. And then what would happen when I would forget, the clients would go a lot of times, we didn't do our inventory today. So developing those safety or those healing rituals, because they're the stabilizers over time, because, you know, clients are coming in from a real, sometimes chaotic world, and they know what to expect from us because they're going to get that same kind of hello, same kind of goodbye. where they're going to get offered a bottle of water or a cup of coffee all the time. So we're the solid objects for them. I'd love to talk about that at some point.
Yeah, no, that's a good, that predictability, like just that predictability and expectation.
Right, right.
It's a great way to get data about a client too, like who might always, I'm thinking of someone who always went in and sat down, I shut the door, that's what we did. One day he shut the door for me and I was like, what the hell's going on today? It's cool to look at those things too.
It is, yes. It's always curious when you are predictable, those moments of unpredictability.
Why are you
really-
sitting on a different couch? Like, hang on, yeah.
They know. They notice.
All right. Well, thank you all so much for joining me here today. Again, season 3 of the How to Be Happy Hour will be looking almost entirely at different types of relationships and the ways in which they intersect with, impede, and sometimes are the ultimate achievement of our quest for our own happiness. Thank you so much, and we'll see you next time.